Okay, this is going to be the first part of our respiratory system notes. Doing a little PowerPoint for that. So get your notes ready and let's start reading them. Respiration, the overall exchange of gases between the atmosphere, the blood, and the cells. The overall exchange of gases between the atmosphere, the blood, and the cells. So number one, your blank there is pulmonary ventilation. P-U-L-M-O-N-A-R-Y, second word, V-E-N-T-I-L-A-T-I-O-N. That's breathing. The inflow and outflow of air between the atmosphere and the lungs. When you ventilate a room, you just air it out, like with a fan or open the windows. And pulmonary ventilation is the inflating and deflating of your lungs, that act of breathing. Well, during that act of breathing, something happens. It's number two. It's external respiration. E-X-T-E-R-N-A-L. And second word is just respiration. The exchange of gases between the lungs and the blood. This is where carbon dioxide is given off by your blood and oxygen is taken into the blood. This occurs at the lungs, across the alveoli, the air sacs, and the capillaries that are surrounding the air sacs of your lungs. Number three is internal respiration. I-N-T-E-R-N-A-L, respiration. The exchange of gases between the blood and the cells. So this is when the blood leaves your lungs and is pumped out to your body. Oxygen is supplied to your cells, and carbon dioxide, the waste gas, is picked up by the cells. This is the red blood cells. So, we have a picture of the respiratory system here, and you can see that it involves, we'll talk about this in a minute, the nose, the nasal cavity, the pharynx, the larynx, the trachea, the bronchi, and the alveoli here with several muscles. The diaphragm is one, and your external intercostals, the muscles between your ribs, are the other pair or a set of lungs. So you all know what a nose is, just your external structure. Let me get my little pointer here. Your external structure here on the front of your face. It contains nasal bones. You see the nasal bones here on the bridge of the nose. You saw those when you were doing the skull. And a lot of hyaline cartilage that makes up the outer portion of your nose. You have muscle around the cartilage. That's how you can make your nostrils flare a little bit. There's skin which covers the outside. And your external nares are called your nostrils. That has nares here on your picture. A nares is a nostril. And comparatively, since you have a pair of internals also, these are called external nares. Now the internal structure, we're going to look at a little bit on this one and a little bit on the next one. This is a human here. You have the nasal cavity, so that should be nasal cavity, not concha. And this area in here, when air enters through your nostrils, your external nares, it has to pass across these nasal concha, which have a mucous membrane covering them, and it's a highly vascularized mucous membrane. And so this nasal cavity is going to warm and filter the air because of it's being highly vascularized on those mucous membranes. At the very top, you can see the olfactory nerves. So smell sensations are picked up. It's at the very top of your nasal cavity. And it serves as a hollow chamber for your speech. This will affect the tone of your voice. Now, the pharynx, this is how you pronounce that word correctly, like the state fair, and then inks, like a ink pad inks a stamp. Pharynx, not pharynx. This is Latin, and Latin is pronounced just a little bit differently. So it's the pharynx. That's going to be your throat. So that's going to be the throat. And there are three areas of the pharynx. The pharynx is this back tube. You can see where I'm pointing now. This is a back tube here called the pharynx, and there are three areas of the pharynx, and they're named after the areas that join them. The nasal cavity here joins the back of the throat, and the area is called the nasopharynx. It's where the nasal cavity joins the back of the throat. Well, the oral cavity, where you ingest food, you chew it, and you drink liquids, they go into the back of the throat also. And where the oral cavity joins the throat is called the oropharynx. And then a little further down, you have this structure called the larynx, L-A-R-Y-N-X. That's how you pronounce that one, larynx, not larynx. Where your larynx joins the back of the throat, this is how you get air into your respiratory system. That area is called the laryngopharynx, or the larynx, your voice box, joins the back of the throat. Now, they don't show it, but right here where I'm pointing is an opening that air enters into your respiratory tract. And it's called the glottis, but they don't have it labeled here. And this is the epiglottis. We'll talk about that in just a minute on the next slide. So here is the larynx, L-A-R-Y-N-X, larynx. That's your voice box. It's composed of cartilage and contains your vocal folds. So you look over here and you'll see vocal fold, true vocal cord. These are thin little pieces of tissue that stretch across there, and you let air pass by and they vibrate. Now, looking at the pieces of cartilage here, the largest portion here, and I show it on the left, is called the thyroid cartilage. That's the name of that cartilage. It's named that way because the thyroid gland is close to it. It lays very close to it, so they named that piece of cartilage thyroid cartilage. It's actually composed of hyaline cartilage, so the type of cartilage it's made up of is hyaline cartilage. All this is hyaline cartilage in here. We'll look at two parts, and the third part's not, but this thyroid cartilage is named, that's its name, your Adam's apple. Right below it is another large piece of cartilage called the cricoid cartilage. It's also made of hyaline cartilage, but its name is the cricoid cartilage. The third piece of cartilage we're going to be concerning ourselves with is at the top here, called the epiglottis. Epi means upon, and glottis is the opening to your respiratory tract. It looks like a little tongue here on the left, and here it is on the right. It's actually a little flap, and it will flip down over and cover the opening of the respiratory tract when you swallow. This opening, in the area where it has this cuneiform cartilage, that there's a hole there, and that's called the glottis. And this epiglottis will fold down every time you swallow and cover the airway opening. So the epiglottis covers the glottis, G-L-O-T-T-I-S. And let's look back at the slide right here, and this opening where I'm pointing to is where this is going to flip down. So when you swallow food from your mouth or drink fluids from your mouth, the swallowing reflexes, this piece of cartilage flips down and covers the opening, and then the food passes by and goes on down to your stomach. And when the swallowing reflex is through, after you've swallowed whatever you're ingesting, the epiglottis pops back up and your airways open again and you can breathe. Now here is a cross section of this structure called the trachea. You can see it on this slide here. Here's the trachea. It's your windpipe. You can feel your throat and you feel the ring-shaped cartilage in your throat. That's your trachea. And the tracheal cartilages, they're made of hyaline cartilage also. So when we look at a cross section of this trachea, which you probably called your windpipe, it is made of hyaline cartilage, and there it is right there. I have it boxed, and I'll show you that that's what the cartilage looks like. If you remember from the tissues, you see the chondrocytes there, the little cross-eyed cells, and you see that the background is clear, and the hyaline implies clear. Well, that's what this blue cartilage is here on this cross section. Why do you think the trachea is made of hyaline cartilage, or just made of cartilage in general? Well, the reason would be to maintain an open airway when you need air. If you have to suck air in real fast, this will not collapse on you like a rubber tube would, like a muscle possibly would. It stays open. And you can see that it's described as being C-shaped. If you look at the blue cartilage, you see it does form a letter C. D-shaped, there's a muscle across the back called the trachealis muscle. So that would make it like a capital D. And ring-shaped, it is circular. So let's look at something. The lining of this trachea, the inside lining, you can see that on the right-hand side it shows the pseudostratified ciliated columnar epithelium. And when you remember from general biology, I mean from the first part of anatomy, you saw this in your tissues. They're column-shaped cells. There are a bunch of goblet cells in here, and they all have cilia on them. And this bottom picture shows a scanning electron micrograph of the cilia. You see some long cilia here. Now, this trachealis muscle on the back, that's smooth muscle, and you look what's behind it. The esophagus is behind it. The esophagus is the tube that food goes down when you swallow it, when you ingest it. And it's going to go down as a swollen mass called a bolus, and it makes this esophagus swell out a little bit. Well, this trachealis muscle allows some give into the back of the trachea. And you know that you've swallowed stuff before that was kind of large, too much to swallow, and it hurts. There are two reasons. The esophagus is being stretched, and this trachealis muscle is being stretched as it's pushed into the space of the trachea. So that's why you have that pain when you swallow something that is actually kind of too big. Now you see here's the trachea here, this single tube, and like I said, you can feel that in your throat. Well, it's going to divide itself. You see where it splits here. That piece of cartilage where it divides is called the carina, C-A-R-I-N-A. It says a cartilage ridge where the trachea divides into left and right primary bronchi. Now you see on here, I have a right. This is wrong. This should be left. So correct this on your notes. This is left side here. I got the pictures labeled wrong. And the other side is the right primary bronchus. As this branches more and more and more, the percentage of cartilage decreases. Okay, so the percentage of cartilage is going to decrease as you go deeper. And the percentage of smooth muscle increases. And it's not a whole lot, but it's just a little bit of smooth muscle. Now, the primary bronchi, remember this on this side over here, this is the right. The right bronchus is shorter and more vertical than the left. Remember that picture's wrong. Than the left. So the right primary bronchus is the first branch off of the trachea. The right bronchus is shorter and more vertical than the left. Now, the main advantage you could come up with on this is that if you inhale something, it will tend to fall to one side of your respiratory tract and not tend to block off both sides. So it could possibly have a survival advantage by this happening. I've had several students whose children have inhaled things like coins, and they all fell on the right side. The secondary bronchi are branches off of the primary. So let's look at secondary. Here's our trachea. You see that there's your primary bronchi. I've got this one fixed. This is the right on the right side and the left on the left side. So branches off of the primary are called secondary bronchi. Secondary bronchi divide into as many branches as there are lobes of the lung. The right side of the the right lung has 3 and the left side has 2. And you probably noticed that I did label that on this picture. The right side has 3 lobes, a superior, a middle, and an inferior, and the left side has 2, a superior and an inferior lobe. You could go further off of these secondaries and go tertiaries. Those are smaller branches off of these secondaries, and it goes on and on and on. Well, you get down to the very last end of this tree of branching, and you have terminal bronchioles. Now, the terminal bronchioles shown here is it's made of simple cuboidal epithelium. Well, bronchioles, this is a little bit higher on your notes, contain no cartilage. Bronchioles do not contain cartilage. That's why these terminal bronchioles are simple cuboidal epithelium. All the cartilage has been lost, and even the cell type has changed. Remember, the inside lining up at the trachea and the nasal cavity in the trachea and the primary bronchi was pseudostratified ciliated columnar epithelium. Now is cuboidal epithelium. Now, asthma is an allergic reaction which causes constriction of the bronchioles. So there is some smooth muscle around these bronchioles. It's just not shown here. And when they do that, it constricts the access to the alveoli, and so you don't get the oxygenated air. You can't oxygenate your alveoli because these are closed off. Epinephrine is used to relax or smooth the smooth muscle and open the airway. So those bronchodilators have epinephrine or some other agent in them that when it's nebulized, when those puffers, when you puff it, you're supposed to inhale deeply. The real fine droplets will get deep into your respiratory tract and relax that smooth muscle and open up your airways again. Now these are a lobule. Let's look at the definition of a lobule. Contains many alveoli. Alveoli are the air sacs the gas exchange occurs across, and these are at the very end of the branching of all these bronchioles and get down to your terminal bronchioles and stuff. This is the very end. Contains many alveoli, arterioles, very small arterial capillary beds, venules, the other side of capillary beds, lymphatic vessels, and a terminal bronchiole. So here's your terminal bronchiole, and there's your lobule, this big cluster of cells. The terminal bronchiole leads to alveolar ducts, which terminate into alveoli. So here's a terminal bronchiole. Here's a blow-up of the bronchiole. And you can see that the alveolar ducts are at the end. So the terminal bronchiole leads to alveolar ducts, these little air cells. So let's look at what they look like. Here's a scanning electron micrograph, picture, and here's a drawing. So on this drawing, you can see that the alveoli are air sacs, and these air sacs happen to be made up of simple squamous epithelium, which we'll see in just a minute on the next slide. In fact, let's go ahead and look at that, and we'll come back to this one in just a minute. Here's an air sac here. You see you have probably 1, 2, 3, 4, and part of a fifth one, maybe a sixth. But you have one nice big air sac here on this left picture, and you can see that it is composed of simple squamous epithelial cells. So it's not one cell that makes up an air sac, it's many. It's a patchwork of these simple squamous epithelial cells that make up each of these alveoli, and there are millions of them. Gas exchange occurs across the alveoli, across these air sacs, and you can see the gas exchange over here on the right-hand side picture. Oxygen is taken on to the red blood cells, and carbon dioxide is given off into the alveolus. And so when you exhale carbon dioxide. When you inhale, you bring in more oxygen. So what the alveoli are composed of are simple squamous epithelium. And then you look at these little blue cells here. These are fixed macrophages. They stay there. And anything that possibly gets that far down into your lungs, like bacteria or some pollen or whatever, the macrophages will clean it up so that it cannot infect your lungs. And then there's another type of cell, these little green ones. These are called septal cells. The new term for them is surfactant cells because they produce something called surfactant. So let's look at your little paragraph there. The septal cells, or like I told you, surfactant cells, produce surfactant, S-U-R-F-A-C-T-A-N-T, surfactant, a liquid which reduces surface tension in the alveolus, thereby preventing their collapsing, so they can't collapse all the way. They're never going to be completely empty. They're always going to have some air in them. Now put in here, respiratory distress of the newborn is a problem preemies have because these surfactant or septal cells are not mature enough to produce surfactant. And what happens with them is when they take their first breath, it's a labored breath, and they exhale, their alveoli completely collapse. And the next breath is like the first breath. It's a laborious inhalation, and then when they exhale, it completely collapses. So they get nebulized with a synthetic type surfactant, which makes sure that the inside of their lungs has the surfactant coating the alveoli so that when they exhale, they don't exhale all the way, and it's an easier second breath, and from then on, all the breathing is easier. As they age a little bit, the surfactant cells will mature and start producing surfactant naturally for them, and it doesn't take very long, but a preemie is born, before they're supposed to be, and so after a while, the surfactant is produced by these surfactant cells. Now the alveolar capillary membrane is over here on the right-hand side, and you can see where it's blown up from. The alveolus, here you see the nucleus of that simple squamous epithelium of that alveolar cell. It's extremely thin. And you see the capillary, which is also made of simple squamous epithelium. It's very thin, and there's a red blood cell, and you can see the nucleus of that simple squamous epithelium cell too. So the alveolar capillary membrane, the layers through which oxygen and carbon dioxide diffuse. Now, number one, simple squamous epithelial cells and alveolar macrophages are going to be inside of here, but you have the simple squamous epithelial cell here on the left, and you see it's very, very, very thin. The epithelial basement membrane and the capillary basement membranes, those are going to be the secretions from those two capillaries, which help hold the, between the alveolus and the capillary. Those are both simple squamous epithelial cells, and they both secrete that basement membrane to hold the two together. And then you see the endothelial cells of the capillary. So you have two simple squamous epithelial cells that are bound together by their lamina, the propria that they produce. They're the basement membrane, and gas exchange occurs across that membrane. It's an extremely thin, like 5/1000th of a millimeter distance, and so gas exchange can occur relatively easily across that endothelial capillary membrane there. The lungs. Okay, the right side has 3 lobes, which we saw a minute ago. The left side has 2. We saw that. There's an invagination called a hilus. Hilus and hilum are the same thing. And you can see I circled it here. So H-I-L-U-S or H-I-L-U-M, either one goes in that blank. So an invagination, an indention in the lungs called the hilus is where the primary bronchi enter or exit. The pulmonary arteries enter and the pulmonary veins exit. The lung, each one of them has a hilus where vessels enter and exit. And let's look at something too. We'll look at the cardiac notch. You see that the left side has a little notch in the lung called the cardiac notch, and that's basically where the heart is slightly to the left, and so it impinges or it takes up space where that lung is, and then that lung has modified itself, and there's a cardiac notch. So in your notes it says there is a cardiac notch for the heart. There's also serous membrane. So let's look at this picture first. A serous membrane surrounds each lung called the parietal pleura. Now you remember parietal means wall. It's a wall or a sac around an organ. Now pleura is the serous membrane which surrounds the lungs. So you see where that arrow is, where that little line goes to. It's a sac, that little blue sac that goes around the lungs. It's not touching the lungs. It's not on the surface of the lungs. It's a sac around the lungs, and it's on the thoracic cavity wall. This serous membrane reflects back over the surface of the lung as the visceral pleura. So it does. You see the visceral is going to be the little red line on the surface of the lung. Visceral means organ, and the lung is an organ. So that's the visceral pleura. And there's a space in between the pleural cavity. This is where they both secrete fluid into, so that when the lungs inflate and deflate, there's a sliding that goes on. Sliding goes on. Now you can see that again over here on this picture. You can see the pleural cavity, that's the space. You can see the visceral pleura on the surface of the lung, and the parietal pleura forming the sac or the wall around the lungs. Now, respiration is the exchange of gases, that's oxygen and carbon dioxide, with the cells of the body. And we're going to look at something. We have some definitions here. Number one is called pulmonary ventilation. Gas exchange between the atmosphere and the lungs is part of pulmonary ventilation. That's going to be your external. Well, external is going to be involved, but remember, ventilation is just the lungs inflating and deflating. So let's look at this thoracic cavity before we start this. I have a picture here on both sides, and you see the trachea and you see the lungs there, and then I have a little blue line. I'll look at the one on the left. You see that's your thoracic cavity. At the bottom of your thoracic cavity, where we have this little dome here, that is your diaphragm. A little dome structure, that represents a muscle called your diaphragm. And the walls of this thoracic cavity, you remember you have external intercostal muscles there. So we're going to look at how inspiration and expiration occur. And it's going to involve something called Boyle's law. So look at number 2, which says inspiration, and that is a decrease in the intrathoracic pressure. So look at the one on the right, a decrease in the intrathoracic pressure. All right, so it says an increase in the size of the thorax. And we have Boyle's law. Boyle's law is an inverse law. And you look at my little equation there. As the volume is increased, or if you increase the volume, it results in a decrease in pressure. Now look at the little red arrow there. You see that the diaphragm has gone from where it was in the relaxed position, the dotted line, is contracted and gone down to more level. That increased the size of the thoracic cavity. It increased the volume. And the external intercostals that are in the walls of the thoracic cavity, when they contract, they lift and raise your rib cage up. So take a deep breath. You know that your chest cavity enlarges. It's due to the external intercostals pulling on the walls and lifting your rib cage up and out to increase the volume. And your diaphragm went down, so that increased the volume. Well, when the volume is increased, the pressure decreases. Now, I put some imaginary numbers in here. Look at inside here, I have 758 millimeters of mercury. That's less than the ambient pressure of 760. That's a gradient. 760 is greater than 758, so air is going to enter the lungs. So as the volume is increased, your thoracic cavity increased volume, that decreased the pressure inside of your thoracic cavity, and air is drawn in. So your little definition down there says diaphragm contracts and flattens down, which increases the thoracic cavity's volume and decreases the intrathoracic cavity pressure, and the lungs inflate. This is an active process. It's an active process because two muscles are contracting in order for this to occur. The external intercostals and the wall of your thoracic cavity between your ribs, and your diaphragm. Now, those aren't the only two, but those are the main two. This is kind of like a syringe. You know, a syringe is a barrel and it has a plunger in it, right? And you know that when they stick a syringe, like a nurse or a doctor, in that little bottle, and they pull the plunger down, that's increasing the volume, isn't it, inside of that syringe? There's an airspace in there now. Well, they increased the volume, which decreased the pressure, and that's what sucked that fluid into that syringe. So that's a similar advantage, an analogy to the lungs inflating. Let's look at number 3, expiration. Here's your thoracic cavity again. You see the walls, and there's your diaphragm, which has gone up now. Okay, so expiration and increase in intrathoracic pressure. Well, when you exhale, several things happen. The external intercostal muscles relax, and when they relax, your chest falls down, your thoracic cavity collapses. And when the diaphragm relaxes, it goes from that dotted line back up to its relaxed dome shape. You see that the thoracic cavity is actually smaller. Well, an increase in intrathoracic pressure, okay, the volume is smaller, which results in an increase in pressure. That's a decrease in the size of the thorax. You see that the pressure inside now is 763 millimeters of mercury, higher than 760 in the ambient pressure around you in the air, in the environment. And so it's another gradient. The pressure is higher in your thoracic cavity than it is in the air around you, and so you exhale. So reading that little explanation down here, diaphragm relaxes and returns to a dome shape, which decreases the thoracic cavity's volume and increases the intrathoracic cavity pressure, and the lungs deflate. So this is like when the plunger of the syringe is pushed, that decreases the volume, which increases the pressure, and the fluid leaves the syringe. So exhalation is a passive process. The diaphragm is relaxing. The diaphragm relaxes, so do the external intercostal muscles. Now you can force air out, but that involves several other things. That involves your internal intercostal muscles pulling your rib cage down closer to collapse your thoracic cavity, and it involves your abdominal muscles contracting and forcing the organs up a little bit to push that diaphragm higher. So forced exhalation, that's an active process, but regular breathing, inhalation is active, exhalation is passive. Now we have something called eupnea, and that's in your notes. It says normal, quiet breathing. This is only the elastic recoil of the lungs. We didn't look too closely, but let me show you something real quickly. Up here, around these alveoli, there's smooth muscle, and there's elastic fibers that help you to exhale it helps you exhale because it collapses the alveoli when you exhale. So it helps air to leave your lungs. Costal breathing, costal has to do with the ribs. Shallow breathing, the external intercostals are just contracting a little bit, and your diaphragm's going down a little bit, and you're breathing kind of shallow. Atelectasis. Atelectasis is a collapsed lung. It's a complete or partial collapsing of a lung, which could be done by several things, like a hole in your thoracic cavity, like from a bullet or something, or a knife or something like that, or something sticking into your thoracic cavity, or even an infection, like pneumonia could cause a weakening in the alveoli, and one of your lobes could kind of like pop, and those have to be taken care of by putting a tube in your chest for a while to drain fluids. Compliance. The ease with which the lungs and thoracic cavity expand and contract. It depends on the elasticity of the lungs, like the elastic fibers that you saw around the alveoli, that's one, and by surface tension, lowered by the surfactant. Diseases or problems like emphysema. That condition could be caused by a variety of things. Smoking is one of the big ones that can cause emphysema and lung problems. And you've probably seen people walking around with little oxygen tanks, and they have that little harness that has the two little catheters that go up in the nose. That's so that they can receive more oxygen than is in the environment because they have less compliance of their lungs. Scar tissue builds up, and the lungs cannot inflate and deflate as well as they used to, and so you can't oxygenate your lungs as well as you used to, which means that there's less oxygen going to your tissues also. And so the amount of inhalation and exhalation that they can do needs to be maximized with a higher oxygen content when they inhale air, and so they have to wear oxygen. So emphysema is not curable at this point. That's scar tissue, and it damages your lungs, and it's a bad way to go. We're going to stop this one. We'll pick up part 2 in just a minute.